Surgical management of advanced renal cell carcinoma, cytoreductive nephrectomy. Approximately 30 to 40 patients will present with the metastatic or advanced RCC, and for this patient multimodality therapy will include surgery and has produced improved progression-free survival, overall survival. And prior to introduction of targeted therapy for RCC, recommendation was for cytoreductive nephrectomy with or without metastatectomy prior to systemic treatment as the primary treatment option for patient with stage 4 RCC. And the data supporting this recommendation come from 3 RCTs demonstrating survival benefit of patients who have received systemic immunotherapy with the interferon alpha after surgical removal of primary tumor. And the initial study found the median survival of 120 patients assigned to surgery followed by the interferon alpha to be 11.1 months compared to 8 months for 121 patients assigned to interferon alpha alone. A subsequent study found time to progression was 5 months versus 3 months, and a median duration of survival to be better in patient randomized to surgery plus interferon alpha compared to those randomized to interferon alpha alone. And combination of the survival data from this trial resulted in a median survival of 13 months versus 7 months patient undergoing surgery in addition to interferon alpha compared to interferon alpha alone. So more recent data accounting for the current use of targeted therapies as a first-line therapy for patients with the metastatic RCC has confirmed the survival advantage associated with the cytoreductive nephrectomy. And a large retrospective study arising from the NCI database, 15,000 patients treated with the targeted therapy evaluated the role of cytoreductive nephrectomy. 35% patient had the cytoreductive nephrectomy between 2006 to 13. Patient with young age, private insurance treatment or academic center, lower tumor stage and node negative stage were more likely to have cytoreductive nephrectomy. And in sensitivity analysis using propensity score adjustment as well as other covariants, patients with cytoreductive nephrectomy had a lower risk of death, and the overall survival benefit with cytoreductive nephrectomy was 0.7 and 3.6 months in patients who survived less than 6 and less than 24 months respectively. And a second and last retrospective study from the International Metastatic RCC Database Consortium validated the finding with 20 months for cytoreductive nephrectomy, 9.8 months without surgery in patients 1600 RCC patients presenting with symptoms of metastatic disease. And following adjustment of this IMDC risk categories, cytoreductive nephrectomy remains an important predictor for OS, and that cytoreductive nephrectomy should be offered for all patients expected to have more than 12 months of survival and those who have less than 4 IMDC risk factor. And despite this promising results, rates of cytoreductive nephrectomy appears to be decreasing with the introduction of targeted therapies. And so 50% decreased with the introduction of targeted therapy in 2006, further declined to 38% in 2008. And this phenomenon was confirmed by the Sutka et al. Using US private insurance database tracked the use of cytoreductive nephrectomy over 10 years period, and decreasing trend in cytoreductive nephrectomy utilization is a reflection of the morbidity that cytoreductive nephrectomy imposes in already vulnerable population. Use of laparoscopic minimal invasive technique can potentially provide less invasive, less morbid method. Cytoreductive nephrectomy is still not without risk. Surgical assessment needs to be considered preoperatively. Abdullah et al. Evaluated 70,000 patients with Florida inpatient database underwent nephrectomy, and patient who underwent cytoreductive nephrectomy found that these patients were more likely to have longer length and secondary surgical procedure and in hospital mortality and a prospective complication. And in these reports, increasing age was predictive of increasing in hospital mortality and complication for those undergoing cytoreductive nephrectomy. And according to the prior reports, patients that are most likely to benefit from cytoreductive nephrectomy are those patients with lung only metastatic disease, good prognostic features defined by Modzell criteria, and conversely, and good performance status. Predictors of shorter survival for patients with the advanced RCC include elevated serum LDH, then hemoglobin less than 10, lower limit of normal, correlated with the serum calcium of more than 10, interval of less than 1 year from the original diagnosis of the start of the systemic therapy, and Karnofsky performance of less than equal to 70 and 2 or more site of organ metastasis. The challenges associated with the risk criteria is mostly account for the association with the disease and do not consider the perioperative risk to the patient, which may be significant. And the surgical management of a patient with metastatic disease has completely different set of standards to those faced in curative procedure. Complications associated with the cytoreduction, even in the most minor case, can lead to significant consequences in the patient's overall oncological treatment. And as a result, two randomized trials, that is Carmina and Sure Time, they were launched in 2009 and 10 to define the impact and consequences of which cytoreductive nephrectomy should be used in combination with the targeted agent. Carmina patients, they are randomized to upfront nephrectomy followed by sunitinib versus sunitinib alone, and short time investigation nephrectomy followed by sunitinib versus sunitinib followed by nephrectomy in the absence of progression. Unfortunately, actual for these trials has been challenging, leading to the early closure of the Short Time. Short Time showed that the sequence of targeted therapy had no effect on the DFS, with the benefit seen with regard to OS in cytoreductive nephrectomy deferred group. The limited sample size precluded a definitive conclusion, and Carmina trial enrolled 450 patients of sunitinib alone was non-inferior to cytoreductive nephrectomy for sunitinib group. Again, questioning the use of cytoreductive nephrectomy in patients presenting with the metastatic RCC. And it is important to note both trials were enriched with the intermediate poor risk group. Patients which have biased the results obtained. That being said, these results are in line with smaller phase 2 trials that have shown the survival benefit using short period of targeted therapy as a litmus test for cytoreductive nephrectomy. Paulus et al. Used 12 weeks of pazopanib prior to cytoreductive nephrectomy, demonstrated disease reduction of 84% in patients with 61% proceeding to cytoreductive nephrectomy, and more importantly, so that the patient who had evidence of progression prior to cytoreductive nephrectomy are particularly poor oncological outcome. And in summary, the use of CN, cytoreductive nephrectomy in patients with the metastatic RCC, has come into question with the use of novel therapies, and following the reporting of this Carmina and short-term trial, the aiming of cytoreductive nephrectomy remains controversial, with some studies showing that trial of targeted therapy at a litmus test for cytoreductive nephrectomy may aid in patient selection. Recent data note that surgical risk associated with the cytoreductive nephrectomy are not insignificant, and especially in the elderly patients, comorbidity with should be weighed against the patient's disease biology before reflecting proceeding with the surgery. Thank you.